Welcome to our case study, Craig spinal cord injury, C5. Craig is a 36-year-old Asian man with a complete fracture of spinal cord level C5. He's married with no children. He lives on the 5th floor of an apartment building, which has an elevator access. Craig is bilingual, speaking both English and Korean fluently. His family is very comfortable with Korean as her main language. He recently opened a cell phone store and has 2 part-time employees. He has a strong family ties and family lives close by. Craig believes that hard work and persistence will lead to success. Analysis of his occupational performance. We see no deficits in cognition, perception, vision, or hearing through observation of interviews. Sensation is absent distal to C5. He's dependent on all ADLs, transfers, and mobility. He has limited seating tolerance, flaccid paralysis throughout the upper extremity and lower extremity. Right now in his physiological state, he appears despondent, angry, and confused. He really isn't sure how he's going to improve with his condition. And his goal for therapy is to do what he must to get to the rehabilitation hospital.
Okay, so now for Craig's occupations. The areas of occupation we would address during his acute care stay would be his ADLs. His wife works full-time as a receptionist, and he is currently dependent in all of his ADLs. So educating Craig and his wife is a major priority for his stay. Addressing safe transfers and mobility, doing skin checks, pressure relieving methods, range of motion exercises, training and self-care activities using adaptive equipment and compensatory techniques would be ideal. The occupation we might introduce to Craig and his wife for the future would be communication management. So this would be an IADL. He would be able to send, receive, and interpret information using adaptive equipment, such as a computer through voice recognition or use of a typing stick and use of a phone through a headset with voice recognition. So during his 2-week stay, the areas of self-care we would address would be feeding, grooming, and upper extremity dressing. So addressing feeding will assist in the safety of eating and swallowing and making any recommendations for diet and liquid consistency. If we educate Craig on the use of adaptive equipment, we can help assist him in performing grooming and upper extremity dressing with assistance. Given the level of Craig's injury, we don't think he'll be able to completely dress himself by himself. He will be able to raise his arms and bend his elbows, although he has some paralysis associated with his wrists and hands. He'll need assistance, but he'll remain dependent on his lower extremity dressing. He'll definitely require adaptive techniques and equipment to dress. Given Craig's business, we think with assistive technology, his wheelchair, Craig can delegate his job duties to his employees, and he can return to his store after rehab. For performance patterns, we can educate ourselves about cultural factors that might be important for Craig's recovery and intervention planning by asking him about his Korean cultural beliefs, about his family and health when we gather information for his occupational profile. We can also use the therapeutic use of self to understand his beliefs. So his roles that have been affected by his accident. He is a store owner, so he needs to take time off from managing his retail cell phone store as he recovers from his injury. When he returns to work, he may need additional accommodations, such as adaptive equipment to help him carry out his daily tasks. We can introduce the universal cuff to him or an orthosis to support his wrist. And then his husband role, we can educate him and his wife on adaptive equipment that assists them in performing daily activities. By understanding the limitations he has and asking for assistance from his wife, this will be very important to him. For performance skills, 8 to 10 performance skills that should be addressed during his sessions would be handles, navigates, positions, coordinates, endures, adjusts, accommodates, sequences, paces, and calibrates. Given the level of Craig's injury, the motor skills he would be able to perform and the functional tasks that those motor skills could influence. So he would be able to raise his arms and bend his elbow. He'll be able to assist with transfers. He would be able to perform feeding and grooming with a universal cuff. He could work on computers and phones with a typing stick. And then an intervention session to address 3 of the identified performance skills. So he can handle utensils with adaptive equipment for feeding with the universal cuff. He can navigate the wheelchair or proper use of it. And he can pace himself during a grooming activity with the use of adaptive equipment, which will be conservation of energy. To address Craig's emotional state, we'll do education about his spinal cord injury and prognosis. This will open the line of communication to give Craig opportunities to voice any questions or concerns. We'll also use the therapeutic use of self.
So now we're going to go look over his client factors. Given the level of Craig's injury, which is a C5, the muscles who would be fully innervated are going to be the shoulder, especially the deltoids and the elbow flexors, the biceps, and the rhomboids. And then partially innervated would be the serratus anterior. And then the motions that he will have will be elbow flexion, shoulder abduction, and adduction, shoulder elevation, protraction, and supination. To access Greg's upper extremity status, we would be using range of motion, manual muscle testing, sensation testing, and a clinical functional observation of him performing tasks. The name of the severe medical emergency that can be life-threatening to a spinal cord injury patient is autonomic dysreflexia, which would be some pounding headaches, flushed face, sweating above the level of injury, hypertension, and if it does happen to Craig, we can help him by supporting him in the upright position, removing any tight clothing or accessories, and help him empty his bowel and bladder if needed. And we would also notify the nurse. Another possible thing that can happen to Craig while he is having an acute stay would be an orthostatic hypotension, which is a low blood pressure occurs when you stand up from sitting or lying down. Some of the symptoms that we can see can feel dizzy, lightheaded, and nausea. If Craig does experience this, we would have him, depending if he's laying on bed, we'll lower the head of the bed. If he's in a wheelchair, we will lift his legs and recline the wheelchair to place the head below the heart level. If symptoms persist, lay him back down slowly and elevate his feet. We can also use compression socks and ace bandages to wrap his calves to increase venom return of blood flow. Some of the precautions we can use would be keep the head of his bed slightly elevated, move slowly when sitting up, monitor his blood pressure, and ensure he stays hydrated. To instruct Craig in pressure reliefs, we will be doing by manual weight shifts using his biceps and mechanically by using their tilt and recline function on his wheelchair. The directions we will give him will be push up using the armrest so that your butt is off the seat. We would also educate him in bed positioning, as well as frequent change of positions in bed support for any bony areas. During the acute state phase of a spinal cord injury, spinal shock is very common and spasticity is rarely noted. And so once spinal shock subsides, increased muscle tone may be present in response to stimuli, and that's when spasticity would eventually develop in his muscles. Some of the interventions that we can do with Craig to address his flaccid paralysis would be range of motion exercises to prevent contractures and maintain functional capacity, stretching because early mobilization prevents decline in muscle strength, properly support, position, and line the body to minimize or prevent pain and stiffness. Positioning can also help to regain lost movement and limits future problems with movement. Proper positioning also increases awareness of weaker parts of the body, and as well wheelchair training to increase his participation and overcome barriers in his environment, also to increase his mobility. Some of the type of slings that we would recommend for Craig would be a resting hand split, which will be helpful at night for Craig. The split will help prevent contractions and maintain chemosis. A wrist brace can be used during the day to stabilize the wrist and increase function during self-care activities. And as us as staff and family members, we would be educating to look for redness, increased swelling, and pressure sores when taking out the split. As OTs, we would assist Craig in developing sitting tolerance by creating a schedule for Craig to be out of bed and sitting in his wheelchair or bedside chair for a certain amount of hours a day. Recommending a wheelchair with trunk support to enable Craig to begin to practice sitting without the use of his hands for support. As well, use of a pressure mapping to determine comfortable sitting for Craig. And using compression stockings, it is possible that Craig's dizziness upon sitting is due to orthostatic hypotension. Compression can be used to improve circulation and minimize the likelihood of experiencing symptoms of orthostatic hypotension. The safest method to use in transferring Craig from his bed to wheelchair would be transferring him from high to low using a sliding board. The stage of psychological adjustment that we think Craig is in would be denial. He does not yet understand what having a complete spinal cord injury means, and he has not yet faced the fact that he may never walk again. At the moment, he will be experiencing some crying and be emotionally reactive towards others due to his traumatic injury of a spinal cord injury. Some psychosocial supports that are currently available to help Craig deal with emotional status are going to be online forums and support groups, family support from his wife and family who lives nearby. Some of the context and environment that he is at the moment. To ascertain if Craig's and his wife and his parents' culture believes my influence intervention, the OT can ask him open-ended questions while gathering information for his occupational profile, and also looking up any traditional core health beliefs such as fate and karma may be the reason for ill health or injury. Many health beliefs stem from the Buddhist practice where sickness and death are seen as part of life. Just kind of getting to know what the Korean health beliefs are. Some of the important aspects of Craig's personal and temporal context are for the temporal, Craig is in a stage of life where he was thinking about having children in the near future. And then personal is a 36-year-old college-educated male who's owned his own business, so it is very likely that it is difficult for him to cope with the loss of independence. As we mentioned before, some of the adaptive equipment that we might be using for him would be the universal cuff and orthosis. A prescription that we would write for a wheelchair would be a power wheelchair with joystick, pressure relief, cushion, and tilt and recline function. And it might be difficult to navigate wheelchair in a small galley kitchen, so we would need to determine if it's feasible to make modifications to the bathroom and at-home living. Would I recommend any assistive technology like we mentioned? Yeah, so Craig can begin self-care training and can be independent at certain self-care activities. As acute care hospital being the first environment where Craig and his wife are learning about the spinal cord injury, some of the information that we would be giving them would be to facilitate the enlistment of positive coping skills, address safety concerns for patients with spinal cord injury, and any organizations that can be helpful for them, and such as the National Spinal Cord Association and United Spinal Associations. Several risks associated with spinal cord injury would be pressure ulcers need to be checked daily by Craig and his wife. Provide Craig and his wife a chart with stages of pressure ulcers and a checklist of areas in the body to check. And temperature dysregulation. Craig environment temperature needs to be monitored to prevent heat stroke and hypothermia. As Craig's wife wants to be a part of his care, some of his activities that she can assist with would be passive or active assisted range of motion within his strength, ability, and tolerance level.
The frame of reference we would use when working with Craig would be the rehabilitative frame of reference. Because spinal cord injury causes permanent disability that cannot be completely remediated, adaptive devices, compensatory techniques, and environmental modification could be used to facilitate increased independence. We did find some evidence on AOTA to support the use of the rehabilitative frame of reference, as the majority of AOTA's recommendations involve modifications and adaptations which best aligns with the principles of rehabilitative frame of reference. Some of the interventions for spinal cord injury recommended by AOTA include providing grab bars, reachers, and other adaptive equipment to enable performance of ADLs, fabricating an orthosis to optimize upper extremity function, recommending a wheelchair seating and positioning, providing training in the use of assistive technology such as an adapted smartphone for a person with limited hand function, and recommending environmental modifications.